Thank you. Our last speaker is John Concato. John received training in internal medicine, public health, and clinical epidemiology at New York University and Yale University. He's currently professor of medicine at Yale University and director of the Clinical Epidemiology Research Center at the Veteran Affairs Connecticut Healthcare System. His research interests are in screening, diagnosis, and prognosis in prostate cancer, as well as methodological issues related to study design and data analysis in patient-oriented research. John?
Thank you very much. It's an honor and a pleasure to be here. I'd like to also thank the organizing committee and the staff for all the help they provided. I have no formal conflicts of interest, but in trying to calibrate what I've heard others say, I will add, and keeping an eye on the clock, that I first met David Sackett in 1990. I was a trainee, a fellow at the time. My mentors were the late Alvin Feinstein and Ralph Horowitz in the Clinical Scholars Program at Yale. And the same Tri-Society meeting that Ralph had mentioned a couple talks back, I honestly don't remember the topic, but I do remember that David and Alvin were debating, and it left a big impression on me with regard to the importance of methodology. So in addition to many, many things I've learned from the three gentlemen I've mentioned, I'd like to thank them at this time in particular for such a profound influence. Second disclosure would be along the lines of who we work for. I feel compelled to say that I am wearing my university hat, not my federal government hat from the U.S. in the Department of Veterans Affairs. Regardless of what's going on in the news, I will, though, end on a positive note and say that the VA Cooperative Studies Program, to its credit, is now, when research questions are being discussed, unless it's obvious that they're sort of a RCT, it's a new drug device, or a quote-unquote epidemiologic study, a discussion is held across the clinical trial and the observational centers to discuss and decide in a collegial fashion what design might be best. And that's a new evolution, but we're excited about that. I will also finally add that I think the answer to the question, since everyone's been saying that up front, is there's no right or wrong tool. I would agree research designs are flat, and I'll hope to provide a discussion to support that. The specific objectives of mine are consistent with the conference objectives. To understand specific strengths and limitations of observational studies and randomized trials. And if there's an emphasis that might differ slightly, it's not inconsistent with, but I want to emphasize very much the need for methodologic and clinical judgment when evaluating patient-oriented research. And I'll explain what I mean by clinical judgment. It's not necessarily bedside judgment, but it's along the lines of what's come up earlier. Now, royal is in my title, so I didn't go to any dictionary to look up the definition. I went, of course, to the Oxford Dictionary. And the first definition of being a member of a royal family doesn't really apply. But I think one of the other talks today already used the word king. That is, does a randomized trial have the status or power of a king or queen, or is it part of the most successful, famous, or highly regarded group? And I'm not saying that either of these two definitions are bad, but I think we should be aware of what we are doing with hierarchies of research design and the like. Now, this dates from when I first started, say, teaching and practicing as a researcher. So if the RCT was ever evident as being king of research design, I was in clinic, and this was one of the last print copies of the U.S. Preventive Services Task Force before it went online. Just one properly randomized controlled trial was grade A evidence. Well-designed trials without randomization. So the well-designed part, we could get into that, but interesting. Design cohort or case control studies, et cetera. Of course, this has become a pyramid. We also have the grade approach. A lot of evolution, but at the backbone is still that the research design, what might be called the research architecture, is a key, and you start there and you make other adjustments. I would say let's step back for a moment and consider study design in a broader context. Certainly the word validity has come up, as it should, and study architecture is paramount. Randomization is certainly an important method, the predominant method, adjusting for confounding and other approaches. But the source of data, which is obvious as either primary, we run out and collect it, secondary, a database examination, Maybe it's more common among trainees, may or may not have occurred earlier today, but observational studies, it's perhaps evident, don't always use secondary data. And I'm not saying secondary data is always a bad idea. Big data, but whether big data are good or bad, it depends on the question being asked, the design being employed. So I think being precise, we should not, it is not synonymous to say a secondary data source in an observational study, and we also have to ask the question of how validity is affected by the data, not just by the design. Generalizability, external validity, the intended spectrum of patients based on inclusion-exclusion criteria here. I think it's fair to say, on average, that observational studies have an advantage because we are looking at what was actually done. You could just call it real world. It doesn't mean that the randomized trial result is wrong. It just means it's addressing a different question. And as also come up today, the impact of participation itself or how that plays out. Here I've just listed the Hawthorne effect, that the outcomes can differ just by participating itself. Each one of these topics, of course, would take, if not 20 minutes, an hour a day, a conference. We could go into as much detail as we choose to, but mainly I just wanted to step back and say if we only use design and say randomized observational and that's driving everything, we are really just picking one of these elements out and not considering them all. Now, I could talk on and on about the strengths of randomized trials. I do not deny any of them. And likewise, it's really easy to do a poorly conducted observational study. But yes, I am trying to spend a bit more time on the undercovered aspects of limitations of RCTs and the under-recognized strengths of observational studies. So the next few slides will cover the red check marks. Just to identify 3 limitations of RCTs, we've sort of talked about these. Randomized trials on the same topic are often contradictory. Dr. Horowitz had identified that some time ago. It's to be expected, certainly statistically there'll be a distribution. One might say it's to be expected clinically, depending on who the patients are, what the intervention is exactly. But that discordance is often overlooked when the New England Journal or pick your favorite journal comes out and we say, aha, a clinical trial today has shown. Secondly, and this came up in other talks, meta-analyses and large, simple trials often don't agree. Other examples were given. This is somewhat underappreciated. It's attributed partly to heterogeneity, et cetera, but I would say, and I think Dr. Yusuf have left, while I agree small trials are probably part of the issue, and having larger trials would help, and other explanations, but it doesn't mean that the small trials were necessarily wrong for the patients, the interventions, the outcome that they were doing. So large, simple trials, you have sort of a gold and platinum standard. If they don't agree, again, research designs might arguably be flat. And then lastly, of course, we all know RCTs can have restricted generalizability. Here, this is a parochial citation. A colleague in nephrology, Dr. Stephen Coca, pointed out, as I say on the next slide here, that cardiovascular disease, and these were prominent, GC, TIMI, pick your acronym, do not provide adequate information to nephrologists, because if you go to the methods paragraph, high creatinine, you're excluded. It's a leap of faith to assume that the intervention will work. That might be described as a problem of omission. Gerlink et al. Described a problem of commission. It wasn't their trial, it was their report that documented after the publication of a randomized trial of spironolactone that itself went by the acronym RALES, R-A-L-E-S, the publication and the implementation of that trial result, which was judged to be valid, was associated with increased morbidity and mortality related to hyperkalemia. Now, we could say, well, it was the bad doctors who didn't go back and follow the inclusion-exclusion criteria as carefully as they should have. Whatever judgment you want to apply, I would just say at face value, it is an example of how the generalizability of RCTs has to be considered. And then last, and more of an overall view, Luce and Goodman, who's speaking tomorrow et al., just stated that many RCTs are ill-suited to meet the evidentiary needs implicit in the Institute of Medicine definition of comparative effectiveness research. And it's not just to be warm and fuzzy and say we're all in this together, but I do agree that there isn't as much difference as we might think between the two approaches, so we have to figure out what's best under specific circumstances. Now, before I flip things around and talk about the strengths of observational studies, and If I hadn't shown this slide before, my point of view is probably evident from some of the comments I made earlier, but we have a spectrum of observational studies. If I say that there are indirect and direct, that's a convenience. I don't mean that indirect should have negative connotations, but as a methodologist, ecological studies, some of which have provided very useful information, let's just remember the unit of observation is greater than one patient or person. A case series doesn't have a comparison group. Let's remember, if you want to invoke penicillin, or it was a beagle, not a human, but insulin, it's not as if we never get useful information, but we can get into trouble. I would think what has done more damage to the reputation of quote-unquote observational studies than anything else is the historical control trial, where a comparison of what's done now to what was done 10 years ago is made, and sometimes it's called a trial, sometimes it's called an observational study, but at the very least, let's identify when we're talking about direct cause and effect evidence, preferably, say, with primary data, that looks at an observational cohort design with a concurrent comparison or a case control study. And I'm just pointing out that there are many variations on observational studies as there are with trials. We talked about cluster trials earlier, or nested case control, where the cases and the control come from a cohort. I'm not saying that's grade A evidence. I'm just saying that depending on the question being asked, it might be the right tool for the job. But here are three strengths. First, strategies can promote validity of observational studies. Dr. Horowitz included randomized trial-like restricted cohorts, specific zero times for intervention that Dr. Redelmeyer used in a different context. It's attention to methodology. Secondly, non-randomized treatments have been shown to be safe and effective. I'm not well versed in FDA regulations and when things changed, but there are some treatments for cancer that were approved prior to requiring phase 3 trials that are still in use as per this publication. And then last, a comparison that found well-designed observational studies do not systematically overestimate results when compared to randomized trials. Regarding this last point, it wasn't just one group. McKee et al. Found that one method does not give a consistently greater effect. I know this has come out earlier, so I'll go through it promptly. Benson and Hartz, that observational results are neither consistently larger than nor qualitatively different from those obtained in RCTs. And then later, observational studies can be conducted using the same exacting and rigorous standards as are used for RCTs. I will here invoke my late mentor to say that I think the answer to the question is no, randomized trials should not be retired, to go back to this slide, despite the strength of observational studies. But it's also true, and this was a prediction in 1995, that as we enter the 21st century that we're now in, it will be impossible logistically, ethically, and fiscally to evaluate all the research questions that need to be addressed. So how are we going to handle that? Well, what might be called the elephant in the room, if we're going to use more observational studies, of course, is confounding. I don't think this audience needs to hear about the threat to validity of observational studies, whereas randomization tends to balance such factors. But here's where I think we're sort of running too fast, leaping to too many conclusions. Well, first, how to deal with confounding. We could conduct only or mainly randomized trials, and to a certain extent that has been, intended or not, the outgrowth of evidence-based medicine. We talked earlier about the infatuation, I might call it, as Sean Tunis showed us, for methods that substitute. Sometimes they're described as mimicking randomization, as with instrumental variables or propensity scores. Now, at the end of the day, empirically, it seems that they're very similar to regression methods. They're not a panacea. They're not magic. And I think it reflects more infatuation with the need to replicate randomized trials than anything else. And the real risk is that it distracts attention and recognition from the other option, which is to use traditional observational methods more rigorously. So we have an expectation almost in many areas, many circles, many funding agencies, of you need an RCT or you need a complex model, and observational studies are held in low regard. Here's another point that I know I'm going to get flack on, but I would say that confounding right now is almost the miasma of the early 21st century. It's something that's out there that is bad, that's going to affect us. This is very conceptual, but at least let's talk about a spectrum. If a confounding factor is known but not accounted for, that's a major methodologic weakness. Design shouldn't happen like that. Granting agencies shouldn't fund it. Journals shouldn't publish it. If it's known and accounted for, it's sound research practice. Now, that's not to say that it's valid, but let's at least acknowledge a third scenario. If it's truly unknown, and it's unknown to clinicians, then clinicians are at least not treating preferentially, and that aspect of bias is not introduced. Now, if all of those patients happen to go to one doctor for another reason, we could talk about that. But there is a spectrum of the impact of the problem of confounding, just as there's a spectrum of the impact of problems in RCTs that we heard about all day. The evidence-based medicine approach, in summary, considers validity to be of primary importance, arguably. Generalizability is considered subsequently. Dr. Horowitz and I, in The Lancet some time back, not as if the word accuracy didn't have enough definitions already, but we applied it to say that the results would be true for the patients who would actually receive the intervention. It's basically to say, let's consider validity and generalizability together. More recently, the idea of using medicine-based evidence to inform and improve evidence-based medicine, the idea of who and where were the patients, what and why were the treatments used, and how and where were the outcomes measured. Of course we talk about this, but it is not systematic. It's in the discussion section. It's an ad hoc, oh yeah, our trial was on older or younger patients. We should spend as much time with a formal systematic assessment as we do, say, with the perfunctory subgroup analysis figure, which takes up a full page in the New England Journal, and it's rare that you have given the restricted inclusion-exclusion criteria, any chance to find a subgroup effect. So I can go through this fairly quickly. This is the same HRT question. All I'll emphasize is that the conventional wisdom is that RCTs are correct, observational studies are flawed, the problem is inherent to design. Here, this hasn't been mentioned. First, let's just recognize that in essentially every other clinical domain, except for cardiovascular outcomes, it's important to note that RCTs and observational studies were highly concordant. Now, it's very important that they weren't concordant in the topic of coronary disease, but as has been mentioned, there are reasons for that. Actually, let me go out of order. Here is what Jan had said earlier, and he mentioned the study. I have the quote for him here. For randomized trials, the start is the natural point of analysis. For observational studies, as we heard, they were users. Fine. I do want to go back to the residual confounding issue. It is true that, and this should not have happened, how do we get the answer ahead of time and not just learn about why the observational study was wrong later in hindsight? This is how. We learn our lessons. We don't do this again. When observational studies did not adjust for SCS, those are the ones that tended to find benefit. When they did, the studies did not. So we should not make that mistake again. Does it mean that the next observational study will be valid, 100% certainty? No, but we have that same problem with randomized trials. And then also going back, I would say that a medicine-based evidence approach is a way to do this prospectively as you're designing a trial. If you start and you say it doesn't take rocket science to say time since menopause, SES, dose of drug, duration of treatment, and the two that I picked out, I already showed you the slides. I took it out of order because so much has been discussed about this already today. Second example, and here are the implications. Rather than HRT keeping women healthy, healthy women were taking it. And then, as per Jan, there was nothing intrinsically wrong with the observational data, and neither design held superior truth. But a second example that doesn't have an answer yet, screening for prostate cancer with PSA, prostate-specific antigen. Observational studies were around, but as we heard in the GYN field, they're dismissed summarily as inferior evidence. 2 major trials were launched 20 years ago. The superficial assessment over time was to await the pronouncement from the king in terms of whether screening works, and these results were eagerly awaited. Yet, RCTs, as has been established for decades, don't always agree. I would say there's evidence of the exclusivity of RCTs in the U.S. Preventive Services Task Force recommendations in 2008. Although in 2002 they considered case control evidence, by 2008 they excluded all such studies summarily to avoid potential sources of confounding that are inherent in non-randomized study. I would say an unscientific decision to cut off data and to just say we're not going to look at it. I was asked to write about this in 2008. It was published in early 2009 before the trials came out. I don't think this is particularly insightful, but I just pointed out that the ongoing RCTs might not be definitive. A statement in the discussion said we should recognize that the King's pronouncement, that is the results of the trials, may not provide a definitive answer to the question of whether screening with PSA decreases mortality. And I actually had Emperor at the time. Your disclosure, I changed it to King to keep with today's title. Here's what was found without getting into the details. European trial had a 20% reduction in hazard ratio with a statistically significant confidence interval. The RCT done in the US did not. I would just point, again, we could have a journal club on this, contamination, other reasons, but at least at face value, the two RCTs are once again contradictory. We don't have an answer. And by the way, this is two representative case control studies, and I can't get over the lottery type odds that give to 2 decimal places the same, not that this is the true value, but the hazard ratio for the US trial and for the US case control study were the same to 2 decimal places by chance, but nonetheless, neither one suggested a benefit. So here, by royal decree, the American Urologic Association said, quote, because there is now evidence from an RCT regarding a mortality decrease with PSA screening, we're going to go ahead and recommend screening. Now, we could fault this decision or this committee or this group, but nonetheless, it is evidence of what's happening in 2013. We should be talking, in my opinion, more about, in research, who the patients are, what the exposure is exactly, and what the outcome is. It'll be much more productive, whether it's in a trial or it's in an observational study. So in closing, there's a spectrum of views on research design. On one end of the spectrum, only randomized treatment assignment can provide a reliably unbiased estimate of treatment effects. Perhaps we have not tried hard enough to convert the skeptics. On the other end, none of the arguments in favor of randomization supplies any practical reason for thinking of randomization as having unique epistemic power. It is, in fact, very difficult to see any cogent reason for thinking as highly of RCTs as the medical community does. Now, I picked these two because they are out on the spectrum and they are talking sort of about ideology, but I will also point out before I close that there are specific criticisms of RCTs, this from 2006, that decisions should be based on the best available evidence to avoid RCT myopia, which is actions that are justified only by RCTs, otherwise we don't know what to do, or actually that's don't know what to do would pertain to evidence-based paralysis, which is no action without RCTs. Lastly, very quickly, it's interesting the New York Times, if nothing else, is not consistent, although earlier evidence was provided about sort of an anti-RCT slant. In 2007, in the Sunday magazine, Do We Really Know What Makes Us Healthy?, they said that the reader should remain skeptical until a randomized trial is done. And at that point, a letter to the editor said the take-home message should be not to expect certainty from any individual study of either design type. Rather, it's iterative and incremental progress. In the long run, we get closer to truth as overall evidence accumulates on a given topic. And as someone else mentioned earlier, putting what we know into practice would prevent more disease than bowing before the throne of randomized trials or worshiping at the altar, which was the original wording. So the summary will borrow from others. The importance lies not in arguing about which methodology is better, but what can be learned about disease activity and therapy from each type of study. And secondly, that decision makers need to assess and appraise all the available evidence, irrespective of whether it was derived from randomized or observational studies. The strengths and weaknesses of each, which we've heard throughout the day today, need to be understood. So there is no shame in accepting that judgments are required. The conclusion would be that carefully designed observational studies can address confounding adequately, not automatically, but adequately, and we know enough now to have a fairly good sense going in. We can adopt a Bayesian approach if we wish to what our confidence is in that regard. I will also say respectfully that it's due to the success of randomized trials that the limitations are often overlooked. But we have to understand and recognize those limitations. But the results of both designs are informative. And lastly, that patient-oriented research needs more medicine-based evidence, that is more methodologic and clinical judgment, as I've discussed. Thank you very much for your attention, and I'll take questions.